Hello friends, in today's lecture we are going to discuss about the mechanism of action of the parathyroid hormone, regulation and the applied aspect of the parathyroid hormone, and lastly we are just introducing the vitamin D. Now let's get started in this lecture. First thing first, mechanism of the action. So parathyroid hormone is used cyclic AMP as the second messenger system. And if you go through my first lecture about receptor and signaling, you already know what the cyclic AMP messenger system and how this messenger system will work. So let me give you a picture. Let's revise a bit. See, parathyroid hormone is going to use G protein coupled receptor. This is the G protein coupled receptor. It has a two domain. One is the extracellular domain, another one is the intracellular domain. Once the parathyroid hormone will bind with the extracellular domain, intracellular domain gets conformational changes and then it bind with the G protein. Now this G protein has a three subunit, alpha, beta and gamma. Now once the parathyroid hormone bind with the cell receptor, this alpha subunit get detached from the beta and gamma subunit and become attached to the GTP and it become energized. Once this alpha subunit get energized, it will bind with this green colored adenylyl cyclase enzyme. Once this adenylyl cyclase get activated, it convert the ATP into cyclic AMP. Now once this cyclic AMP will form in a sufficient amount, it convert protein kinase into the activated protein kinase. It is protein kinase A because A stands for AMP. Now this activated protein kinase will phosphorylate the different cellular proteins and perform parathyroid hormone function. Got it? This is all about the mechanism of action, cyclic AMP messenger system. Now the second one is the regulation of the parathyroid hormone secretion. The most important stimulus for parathyroid hormone release is the hypocalcemia. Hypocalcemia means low blood calcium level. Let me give you a picture. Whenever there is a less amount of calcium inside our circulation, it will stimulate the parathyroid hormone release and this parathyroid hormone will perform its action, and by its action it will increase the blood calcium level. And once the blood calcium level is sufficiently high enough, it will negatively feedback inhibit the parathyroid hormone secretion. So high calcium will inhibit the parathyroid hormone level, low calcium will stimulate the parathyroid hormone level. And the second stimulus is the just opposite to the calcium is the phosphate. Whenever the higher amount of phosphate, it will stimulate the parathyroid hormone secretion. Lower amount of phosphate will inhibit the parathyroid hormone secretion. This is all about the regulation of the parathyroid hormone. Now let's discuss into the applied aspect of the parathyroid hormone. Starting with the first decrease in the parathyroid hormone level is the hypoparathyroidism. So parathyroid gland is not secrete the sufficient amount of the parathyroid hormone. What it will lead to decrease bone resorption. Bone do not get resorbed normally. So osteoclast become almost totally inactive and this will lead to decrease calcium level because there is decreased release of calcium from the bone. And ultimately there is decrease extracellular fluid calcium level and the person will show feature of the hypocalcemia. Now we already discussed what will happen in hypocalcemia. Let's enumerate some of the facts about the hypocalcemia. When the calcium level falls to 6 to 7 milligram per deciliter, T10 will develop, and the sign of the hypocalcemia, if you guys remember, I give you the mnemonic CTC. First C is for the carpopedal spasm, T stands for the Rosseus sign, C stands for Chostek's sign, and the last one is the prolonged QT interval. That changes will be seen in ECG. Now this is about when the calcium level is between 6 to 7 milligram per deciliter, but what will happen when the calcium level is go below down the 6 milligram per deciliter? If you guys remember, there is a spasm of the laryngeal muscle and ultimately it will lead to the obstruction to the respiration and eventually person will die. Now how this hypoparathyroidism is treated? Now this hypoparathyroidism is treated, if you are thinking we have to give the parathyroid hormone, but it's actually not the case. We do not give the parathyroid hormone for its treatment, and the reason for it is the enzyme the hormone is very expensive, and it develop our body develop antibody against it. So by the time you use this parathyroid hormone 2 to 3 times, the person's circulation has already antibody against the parathyroid hormone and prevent its action. So how we treated hypoparathyroidism? The answer is that we have to treat the features. The main clinical features of the hypoparathyroidism is the hypocalcemia. We have to treat the hypocalcemia, and if this hypocalcemia is acute, then we have to give calcium, and in the form of the calcium gluconate. Now this calcium gluconate we have to dilute it in the normal saline in the 10 milligram ratio, and we have to give intravenously. If this hypocalcemia is chronic, then we have to just give a tablet of the calcium, and it contains vitamin D. This is all about the hypoparathyroidism. Let's discuss about hyperparathyroidism. Whenever there is an increased secretion of the parathyroid hormone. So it has two types. One is the primary and another one is the secondary. So primary hyperparathyroidism is about problem related with the parathyroid gland. Problem lies within the parathyroid gland. And secondary hyperparathyroidism, there is a problem other than gland due to other any problem. And the causes of the primary hyperparathyroidism is mainly the adenoma, the solitary adenoma, the simple single adenoma, a small tumor, benign tumor of the parathyroid gland. Second cause is the MEN syndrome. Now if you're thinking what the MEN is, MEN stands for multiple endocrine neoplasia, and this MEN syndrome is basically two type 1 and 2. You are going to learn this MEN syndrome in very detail in medicine and pathology. Right now just remember the cause of the primary hyperparathyroidism. Next one is the HPT-JT syndrome. Now what is this HPT-JT syndrome? HPT means hyperparathyroidism and JT stands for jaw tumor. So it's like that, hyperparathyroidism, jaw tumor. And as far as the secondary hyperparathyroidism is concerned, this increased parathyroid hormone level due to hypocalcemia. Now this hypocalcemia will stimulate the parathyroid gland and it will increase the parathyroid hormone. Main cause is the chronic kidney disease. And this condition, the secondary hyperparathyroidism, is reversible once it has a normal amount of calcium level, once the circulation have a normal calcium level inside it. Now in sometimes MCQ will be asked the difference between primary and secondary parathyroidism. So the answer is like that, in primary and secondary, in both the cases there is increased parathyroid hormone level. The difference is that in primary hyperparathyroidism there is an increased calcium level, while in case of secondary hyperparathyroidism, due to it has a hypocalcemia, it has a decreased calcium level, and just opposite that will happen to the phosphate. Let enumerate it. In primary hyperparathyroidism there is increased parathyroid hormone level, increased calcium level and decreased phosphate level, while in case of secondary hyperparathyroidism there is increased parathyroid hormone level, decreased calcium level and increased phosphate level. Now let's discuss about the primary hyperparathyroidism. So in this primary there will increase parathyroid hormone secretion, and this parathyroid hormone, first thing it will do, it will increase the osteoclastic activity. Once there is increased osteoclastic activity, osteoclast will resorb the bone in a higher amount. It will leads to more release of the calcium inside the circulation, and eventually it leads to increased calcium level. That calcium level may reach to 12 to 15 milligram per deciliter. And reverse thing happens to the phosphate level. There is decreased phosphate level. Though due to osteoclastic activity, more amount of phosphate will be released along with the calcium, but when both this calcium and phosphate reach to the kidney, calcium get reabsorbed, while on the other hand phosphate will be excreted. So in primary hyperparathyroidism there is increased calcium level and decreased phosphate level. Now what will happen when the person suffer from hypercalcemia? The effect of hypercalcemia or the clinical features of the hypercalcemia. The effect is same as the three organs that is involved in the calcium metabolism: bone, kidney, and the GIT. And one additional organ that you need to remember is the effect on CNS. We are going to discuss this in first, then effect on GIT, then effect on kidney, and finally effect on bone. So as far as the effect on CNS is concerned, the person have a depression, then memory loss, fatigue, and finally the poor concentration. These are the features of hypercalcemia on CNS. Now as far as the effect on GIT is concerned, the person suffer from constipation, abdominal pain, peptic ulcer, and lack of appetite. And as far as the kidney is concerned, person have a renal stone. Now in most of the book it will be given like this, that effect on CNS is more commonly known as a psychiatric moans. This depression, memory loss, fatigue, and poor concentration, this is collectively known as psychiatric moans. And the effect on GIT is collectively known as abdominal groans. And finally the renal stone. So these are the effect of hypercalcemia, or the clinical features of the hypercalcemia. You guys are easily remembered like this: psychiatric moans, abdominal groans, and renal stones. Now let's discuss the last one, is the effect on bone. Now as far as this hyperparathyroidism is concerned, because of higher amount of the parathyroid hormone inside the circulation, osteoclastic absorption will be more as compared to osteoblastic deposition. So it will leads to bone may be eaten away. This is the word I taken from the Guyton. Bone may be eaten away, and extensive decalcification will be developed, and this extensive decalcification ultimately leads to the space inside the bone, and that space is filled with the fluid that is known as cyst. So large cystic area will be developed inside the bone, and ultimately because of this cystic area inside the bone, multiple fracture can result from a very slight trauma, and this fracture will be present where the cyst will develop. That cyst that happens inside the bone, that condition is known as cystic bone disease, and in our case it is known as osteitis fibrosa cystica. Remember the term osteitis fibrosa cystica. Let me show you a picture of this osteitis fibrosa cystica. See in this diagram, this tibia showing a cyst formation over the bone, and if you see this in radiographically, it will be look like this. This is not the tibia actually, it is a humerus, but I show you the cyst. How this is how the cyst will be seen inside radiography. Now the effect on kidney. Now as far as this hyperparathyroidism is concerned, there are more amount of calcium and phosphate inside the plasma because of increased absorption from the GIT via vitamin D and increased mobilization from the bone. Now eventually all the calcium and phosphate goes inside the kidney and filtered, and increased formation of the calcium phosphate crystal inside the urine, that is the renal stone. There is increased tendency to develop kidney stone, and there are two type of stone that happens actually. One is the calcium oxalate and another one is the calcium phosphate, and to prevent that stone, the acidotic diet and acidotic drug are frequently used to treat the renal calculi. Now this is all about our parathyroid hormone. Let's get started with next hormone, that is vitamin D. You see the structure of the vitamin D, it is more or like same as the cholesterol. So vitamin D will be formed by altering the cholesterol. Let's discuss how to form this vitamin D. How can we make a vitamin D? Let me give you a picture that you guys get a beautiful idea about how the vitamin D will be formed. Now starting with the top, this 7-dehydrocholesterol, the cholesterol get dehydrated at 7. This 7-dehydrocholesterol, it is actually present inside the Malpighian layer of the skin, and once this malpighian layer of the skin will expose to the solar UV light. Specifically remember this UVB light. It will convert it into cholecalciferol, vitamin D3. So vitamin D3 is not the actual vitamin D, it is a precursor of the actual active form of vitamin D. Vitamin D3 is cholecalciferol, and now to conversion of this 7-dehydrocholesterol to cholecalciferol, you need to remember the exact wavelength of the UV light, that is 280 to 320 nanometer. Now once this cholecalciferol will be formed, it is entered inside the liver via the circulation, and it will converted into calcidiol with the help of this 25 hydroxylase enzyme. This 25 hydroxylase enzyme is situated inside the liver. Alright, and ultimately once this calcidiol will form, it will goes to the kidney and it will convert it to 125 dihydroxy vitamin D. This one is the active form of the vitamin D, and to make this conversion happens, there is 1-alpha hydroxylase enzyme is responsible, and this enzyme is actually the rate limiting step of the vitamin D formation. And the actual location of this enzyme, you see kidney has a nephron, and nephron has a different segment, and this different segment has a different type of cell. So actually where this enzyme will be situated, so the answer would be at the level of proximal convoluted tubule. The cell of the proximal convoluted tubule has a enzyme known as 1-alpha hydroxylase. That enzyme will increase the conversion of calcidiol into calcitriol. So you see this vitamin D is also 25 hydroxy vitamin D, the calcidiol, and vitamin D is also calcitriol, but the active form of vitamin D is the calcitriol. Alright, now one more thing I would like to highlight over here. Kidney also has one more enzyme known as 24 hydroxylase. This one is the 1-alpha hydroxylase. The kidney also has another enzyme known as 24 hydroxylase. Now once our body has enough amount of active form of vitamin D, the kidney will depress this production of 1-alpha hydroxylase enzyme and increase the production of 24 hydroxylase enzyme. And instead of 125 dihydroxy vitamin D, it will form 24-25 dihydroxy vitamin D. That is the inactive form of the vitamin D. Alright. Now let's talk about the regulation of the vitamin D secretion. Let me show you a picture of the proximal convoluted tubule cell. This one is the tubular cell. This one is the blood vessel. Again, it also has a calcium sensing receptor, as I told you in this CASR segment, that this CASR is also present inside the kidney, right? Now, as I told you earlier, rate limiting step of formation of the calcitriol is by 1-alpha hydroxylase enzyme, and it is located over the proximal convoluted tubule. Now this conversion, this rate limiting step, the conversion of this active form of the vitamin D, this one 125 dihydroxy vitamin D, is stimulated by parathyroid hormone and hypophosphatemia, and it will be inhibited by calcium and calcitriol, the active form of vitamin D. Alright. So whenever there are higher amount of parathyroid hormone inside the circulation, it will activate this GAS pathway, cyclic AMP pathway, and it will activate this 1-alpha gene and make more amount of 1-alpha hydroxylase enzyme and make more amount of active form of vitamin D, and this vitamin D will act on the GI tract mostly. And whenever there are higher amount of calcium outside the circulation, this calcium will be inhibit the formation of this 1-alpha gene and stimulate the formation of 24 hydroxylase and make inactive form of vitamin D. Got it? Now let's discuss the action of the vitamin D. Effect of vitamin D. Now as we know that the calcium metabolism will require will be happens at the 3 organ, bone, intestine and kidney. So basically vitamin D has its effect on bone, intestine and kidney as well. and vitamin D has a receptor basically located inside the nucleus, so it has an intracellular intranuclear receptor. And let me show you a picture. This active form of vitamin D, this one is the cell, this orange color is the nucleus. So this active form of vitamin D will be translocated inside diffuse inside the nucleus. It will be bind with the receptor. Now this receptor has a two domain, one that bind with the hormone, another will bind with the DNA. So this is known as the hormone binding domain, another one is known as a DNA binding domain. So the receptor by which vitamin D is going to act, it has a two domain. One is the hormone binding domain. Once the hormone bind with that domain, then and then this DNA binding domain will be activated and increase the transcription of the different gene, right? So mutation of this receptor, that is known as a VDR, vitamin D receptor. Mutation of this vitamin D receptor will ultimately lead to the clinical condition known as vitamin D resistant rickets. Now what is this vitamin D resistant rickets? We are going to discuss in our subsequent slide. Now starting from the first effect on the intestine, the most important effect of the vitamin D is over the intestine. So what vitamin D will actually do at the level of intestine? It will increase calcium and phosphate absorption, right? So let me show you a picture of the GI lumen. See, this one is the luminal side, this is the GI tract cell, and this one is the basolateral side. Over here the blood vessel is situated. So this membrane is known as basolateral membrane, this membrane is known as apical or luminal side of the membrane. Different book use different word. In this case they use luminal side, in some book is known as apical side. Now see, over the lumen, over here there is a gastric juice and all the whatever the food that we ingest present over here, once they are digested by digestive juice, the calcium will be absorbed via this channel. The name of the channel is TRPV5 or 6. That's how it is written in the book. The channel that transport calcium inside the cell from the lumen is TRPV5 or 6. Now you already know the full form of this TRPV5 or 6. It is a transient receptor potential valenoid channel. Let me repeat one more time. Transient receptor potential vanilloid channel 5 and 6. This channel will operate in a concentration gradient manner. Once this channel will be translocated over the luminal side, it will let the calcium move along its concentration gradient and calcium will be stored inside the cell. Now once the calcium will be reached inside the intestinal cell, this calcium will be bind with this binding protein known as cal binding 9K, and make this complex calcium cal binding 9K, and it will eventually decrease the actual amount of free calcium inside the cell. So this gradient will be maintained, and this calcium is the ionized calcium, so it has a tendency to alter the cellular physiology. So by binding the ionized calcium, it will decrease the total amount of free calcium inside the cell. So once the calcium entered inside the cell, this calcium is eventually bind with the cal binding and make a calcium cal binding complex, and this complex will deliver the calcium at the basolateral side to this calcium pump, and this calcium pump is the ATPase pump. Ultimately calcium will be released inside this circulation and enter inside the blood, and cal binding will return to transport new calcium, and this cycle will go on and on. This is the normal cycle how the calcium will be reabsorbed. Now what vitamin D will do in this cycle? So first thing that vitamin will do, it will increase the formation of this channel, this TRPV5 or 6. It increase the number of channel that is present over the luminal side. Second one is it increase this cal binding protein, so there more amount of calcium will be bind to the cal binding, and it will prevent the calcium level inside the cell to rise into the dangerous level. Third one is this one, it will increase the number of this pump, calcium pump, calcium ATPase pump, and ultimately it will increase all the steps of the calcium absorption at the GI level. Now as far as this phosphate absorption is concerned, if you remember our parathyroid hormone lecture, this phosphate is going to absorb by sodium phosphate co-transporter, and inside the kidney there is a sodium phosphate 2 A and C is situated, and I told you at that time that B is situated over the GI tract. So this phosphate is absorbed at the GIT by sodium phosphate 2B co-transporter channel. Now effect on kidney. Now the calcium and phosphate will be reabsorbed by the renal tubule. Vitamin D will facilitate calcium reabsorption at the proximal convoluted tubule by increasing the expression of TRPV5 expression on the proximal convoluted tubule. Now see, this is the difference between the vitamin D and parathyroid hormone. See, in case of the parathyroid hormone, this parathyroid hormone also increase this TRPV expression, but the location is different. This parathyroid hormone will increase this TRPV channel over here, distal tubule, while in case of vitamin D, it will increase this channel at the proximal convoluted tubule level. Got it? And it will eventually decrease the excretion of the substance in the urine. So here's the thing, listen carefully. Parathyroid hormone, it will increase calcium reabsorption and it will increase phosphate excretion, while on the other hand vitamin D will increase calcium as well as phosphate reabsorption. And the parathyroid hormone is also increase the secretion of vitamin D. So what would be the final result over calcium and phosphate concentration? The answer is that once the parathyroid hormone is higher inside the circulation, though this parathyroid hormone is increase the vitamin D secretion, but ultimately finally this calcium will be reabsorbed and phosphate will be secreted inside the urine, because the effect of vitamin D over the kidney is very weak. So the absorption of the phosphate, reabsorption of the phosphate via vitamin D is counteracted by phosphate excretion by a parathyroid hormone. Got it? So ultimately there are more amount of calcium inside the circulation and lower amount of phosphate inside the circulation. Got it? Now effect on bone. Now what is the effect of vitamin D over the bone? See, vitamin D have a receptor over the osteoblast. So vitamin D is going to increase the activity of osteoblast. It will stimulate the osteoblast, and via different cytokines it will has a secondary effect on osteoclast. Secondarily it will increase the activity of osteoclast. So vitamin D has a capacity to do both the thing. It will also increase bone formation. It will also has a capacity to increase bone resorption. Now when bone formation will increase, when bone resorption will increase, that will be depend on the quantities of the vitamin D inside the circulation. If the quantity of vitamin D is extreme inside the circulation, it will increase bone resorption. If the quantity in the smaller amount, then it will increase in bone calcification. Now let's discuss the interaction of parathyroid hormone and vitamin D. So here's the thing, whenever there is a decreased plasma calcium level, it will leads to increase parathyroid hormone secretion. It will stimulate the parathyroid gland and will increase the parathyroid hormone. Now this parathyroid hormone has the effect on bone, kidney and GIT. Let's discuss one by one. This increased parathyroid hormone, once it act on bone, it will mobilize the calcium from the bone and it will eventually increase the plasma calcium level. In kidney, it will increase the renal tubular calcium reabsorption, so it will decrease the calcium excretion. And also parathyroid hormone will increase the activation of vitamin D, and this vitamin D eventually enter inside the intestine and increase the calcium absorption. So ultimately the final result is increased calcium level inside the plasma. So whenever there is a decreased plasma calcium, it will increase the parathyroid hormone. As I told you earlier, the plasma calcium and parathyroid hormone are even inversely related. So whenever there is a decreased plasma calcium level, that will ultimately increase the parathyroid hormone, and eventually parathyroid hormone will decrease calcium excretion, increase absorption at the level of intestine, and increase mobilization of calcium from the bone, and the final result is increased plasma calcium level. Alright, this is all about our today's lecture. In our last lecture, we are going to discuss about the applied aspect of the vitamin D and the last hormone calcitonin. Thank you.